Yes, thank you, Mr. Chairman, ladies and gentlemen. As you all know, volume outcome relationships in pancreatic surgery have been well studied. However, most studies focus only on procedure cutoff values up to 20 procedures per center per year, and very little is known on outcomes above these cutoff levels. So therefore, we chose to study postoperative and long-term volume outcome relationships in pancreatic surgery, including a 40+ volume hospital category. To do this, we analyzed over 3,400 pancreatoduodenectomies for primary pancreatic and periampullary carcinoma, in patients which were registered in the independent Netherlands Cancer Registry between 2005 and 2013. We defined 4 hospital volume categories: under 5 procedures per year, 5 to 19 procedures per year, 20 to 39 procedures per year, and over 40 procedures per year. For postoperative mortality, we chose to analyze 90-day mortality. Of course, we examined overall survival, and we also analyzed conditional survival, so the survival of patients alive as of 90 days postoperatively. In this chart, you can see that during our study period, the number of higher volume centers in the Netherlands increased. And indeed, we know from previous studies that this centralization of pancreatic surgery has occurred in the Netherlands, with a consequent decrease in postoperative mortality. Here we see some baseline characteristics of our patients. The Dutch National Cancer Registry does not contain comorbidity data, so we had to use socioeconomic status and prior cancer history as surrogate markers for comorbidity. As you can see, in higher volume centers, more patients were treated with a higher socioeconomic status. Possibly, patients with a higher socioeconomic status prefer treatment in higher volume centers. Also, in lower volume centers, more often a tumor located outside of the pancreas was operated. And it might be that in higher volume centers, more often a pancreatic tumor is operated because of a worse prognosis of this tumor. During our total study period, in total in the Netherlands, 90-day mortality did not significantly decrease. This while the number of older patients in our population did increase. However, between volume categories, there were significant differences. In the lowest volume category of under 5 procedures per year, there was an almost 10% 90-day mortality compared to lower than 4% in the highest 40+ volume category. When we adjusted for confounding factors, including the period of surgery, a significantly better 90-day mortality was found in the 40+ volume category compared to each consecutive lower category. The same happened for overall survival, which we again adjusted for confounding factors and period of surgery. In each consecutive lower volume category, overall survival was worse than in the 40+ volume category. Our overall survival was comparable to international expert centers. Interestingly, we also looked at some treatment characteristics between volume categories, and in higher volume centers, more often 10 or more lymph nodes were found for examination. More often R0 resection was achieved, and more often adjuvant chemotherapy was applied. Finally, as I said, we also analyzed conditional survival, so the survival of patients alive as of 90 days postoperatively, which we adjusted for confounding factors. And in the 40+ volume category, a significantly better conditional survival was found compared to categories up to 20 procedures per year. Between the 40+ volume category and 20 to 39 procedures per year, there was a non-significant benefit for the 40+ category. This might reflect that the main benefit in conditional survival between these two categories is gained in the direct postoperative period. However, because conditional survival is reflected by the management of late postoperative complications and follow-up such as disease progression and recurrence, it might reflect a difference. There might be a difference in these factors between these two categories as well. Concluding on our study of almost 3,500 Whipple procedures for pancreatic or periampullary malignancy, short and long-term outcome relationships extended up to a 40+ volume category. Our main limitation was that we had no comorbidity data available, and we think that future studies should include a more extensive case mix correction. In future, maybe the Dutch pancreatic cancer audit, which started in 2013, may be used for this. Thank you for your attention.